Hello everyone, welcome to RAAONLINE. I'm Dr. Abinaya. I'm a consultant pediatrician. So we are in the chapter discussion of neonatology, and now I'm going to discuss on hypoxic ischemic encephalopathy. So there are many theory questions as I went through the last 10 years papers. Many theory questions on how do you manage a newborn with hypoxic ischemic encephalopathy, and especially on therapeutic hypothermia. There has been separate 10 marks on therapeutic hypothermia also, and the overall management of HIE newborn is also asked. So let's start with the prevalence of neonatal encephalopathy. So encephalopathy is a broad term. We are going to discuss only on the HIE insult, that is hypoxic ischemic insult. So the most common cause of encephalopathy will be a hypoxic ischemic insult. More than 95% are due to the perinatal events. 3% are non-hypoxic ischemic and only 1% is due to a prenatal insult. So perinatal asphyxia is a major cause of under 5 and neonatal mortality, particularly in developing countries. So neonatal and under 5 mortality. So the latest estimates have mentioned that around 9.4% of the total under 5 mortality worldwide is due to an perinatal asphyxia. And apart from, so perinatal asphyxia is one, prematurity and infections. These are the three most common causes of neonatal deaths, and any prenatal insult is also a very important cause for stillbirth. So coming to the incidence, so this is given in the Nelson textbook. This is as per the NNPD, that is National Neonatal Perinatal Database 2002-2003. So this is roughly for you to understand, that is the incidence of severe perinatal asphyxia. 8.4% of all live births had an Apgar score of less than 7. So this is roughly, you have to remember the incidence. Among these newborns who were born with perinatal asphyxia, the most common resuscitative measure that was used was oxygen, followed by bag and mask, that is positive pressure ventilation 6%, chest compressions only in 0.8%, and medicines were used in 0.5%. So oxygen was the most commonly used resuscitative measure. So coming to the etiology. So the etiologies we can divide as maternal causes and newborn causes, or the fetal causes. Maternal causes broadly, you have to remember that any etiology or any disorder that causes inadequate oxygenation, so any placentation issues, or maternal blood pressure is low, or if there was a preterm labor and premature separation of the placenta, so anything which is impeding the normal blood circulation from the placenta is going to cause a perinatal or a prenatal insult. So inadequate oxygenation from the maternal blood, maybe the mother had a general anesthesia, there was a cyanotic heart disease, respiratory failures, etc. And low maternal blood pressure due to an acute blood loss like a placental abruption or a bleeding placenta previa, inadequate relaxation of the uterus because of preterm labor, uterine tetany, etc., or premature separation of the placenta, or because of umbilical cord prolapse. Also certain maternal diseases like diabetes, PIH, maternal infections, etc. So during the process, perinatal, if the causes pertaining to the fetus, so the baby has a cyanotic congenital heart disease, a severe pulmonary disease which is impeding the oxygenation, severe anemia in the newborn, or shock maybe due to a overwhelming sepsis, massive blood loss, etc., or a drug-induced suppression, or because of a CNS injury, the transition or the baby has failed to initiate its first breath. Some of the causes divide into maternal causes and divide into fetal causes. So coming to the definition, there is no single well accepted definition of the perinatal asphyxia. It is very context specific. We have various definitions from WHO, NNPD and AAP. So WHO has just simply stated asphyxia as failure to initiate and sustain the breathing. NNPD has divided the birth asphyxia as moderate and severe based on the Apgar scores. So, moderate perinatal asphyxia means the Apgar score is 4 to 6 at 1 minute. Severe perinatal asphyxia means the Apgar score is less than 4, that is 0 to 3 at 1 minute of age. This is as per the NNPD's definition. AAP, American Academy of Pediatrics, and ACOG, American College of Obstetrics and Gynecology, they have given the following criteria as the definitions of birth asphyxia. So, all these 4 criteria has to satisfy. First is the pH value. So, pH less than 7 in umbilical cord blood. Apgar score at 5 minutes, it is less than 3. Neurological dysfunction is altered, any seizure, encephalopathy, tone abnormality, evidence of multi-organ involvement, so renal involvement, lung involvement, heart, kidney, renal, any organ involvement. So, all these 4 criteria has to be satisfied, starting from the Apgar score, pH, neonatal neurological dysfunction and multi-organ dysfunction in the newborn. So, these are the various definitions, these are must-knows for all residents. So, in the developed nation, the HIE incidence is low, that is 1 to 8 per 1000 live births, but in the developing nation, the incidence is high, it is 26 per 1000. So, what are we more worried about whenever there is a hypoxic ischemic insult is that the long-term prognosis of these newborns. So, depending on the moderate or severe asphyxia, around 1/3 to half of these survivors will have some permanent neurological impairment. So, it can be cerebral palsy or it can be just a decreased IQ or some learning disabilities or cognitive impairment. Greatest risk, severe outcome, that is severe neurological impairment, cerebral palsy, where the child is completely dependent. So, such severe involvement means if the insult was very severe to cause a pH of less than 6.7, base deficit of more than 25. So, such parameters if you get after the newborn resuscitation, then this particular newborn is going to have severe impairment, or even 90% of such severe fetal acidosis can go for death also. So, consequences of asphyxia, as we know, it is not only just going to cause encephalopathy, but it is a multi-organ disorder, is almost going to affect virtually every organ system in the body, and many of these consequences are going to be fatal. So, HIE means the CNS dysfunction which is associated with perinatal asphyxia is hypoxic ischemic encephalopathy. So, non-specific signs of HIE we will see. So, first is the clinical manifestations. So, whenever at delivery you have a meconium stained amniotic fluid, you know that the fetus was in distress. At birth, failure to initiate the first breath. So, the newborn does not initiate or does not sustain a spontaneous breath. It is a first non-specific sign of HIE, very, very importantly. After which any cyanosis, slow heart rate or apnea or not responding to stimulation, all these are going to be non-specific initial signs of HIE. After which the tone abnormalities will come. Initially there is a limp, and then from a hypotonic state, the baby develop a hypertonic state, or sometimes tone can become normal also. So, the first 24 hours you see that there can be hemodynamic instability, there can be respiratory abnormalities which will need support. After the first 24 hours, cerebral edema may develop which causes a profound brainstem depression. So, this is the time the seizure activity will occur. Most often the seizure activity will occur at the end of 24 hours, or if it is very severe, within the first 24 hours seizure activity occurs. Severe birth asphyxia will have a severe and refractory seizures. Babies will have poor respiratory efforts requiring respiratory support, cardiovascular support, etc. We know hypoxic insult can occur, can result in multi-organ dysfunction. So, we need to support all the organs. First, starting with the heart, the newborn might have a cardiogenic shock. So, supporting with fluid boluses or milrinone or the cardioinotropic support has to be given. Supporting the respiratory system by giving surfactant, because asphyxia can cause the surfactant deficiency or inactivation of the surfactant. If there is a PPHN, supportive care for PPHN with inhaled nitric oxide etc. has to be initiated. For GIT, there can be gastrointestinal perforation, so support, total parenteral nutrition has to be given, and depending on what injury is there, if it is an acute kidney injury, liver injury, so depending on the injury, the supportive care has to be customized. So, classification of hypoxic ischemic encephalopathy, there are 3 different classifications, starting from the detailed classification given by the Sarnat and Sarnat classification, which we all were traditionally we were learning the Sarnat and Sarnat. Now, there is a Levine's classification which is done routinely, and recent addition to this list is the Thompson score. So, 3 different scores given by 3 different bodies, and Sarnat and Sarnat, Levine's and Thompson's scoring. So, this is the modified Sarnat and Sarnat scoring. So, this is again will classify the encephalopathy as mild, moderate and severe. So, based upon these criteria, so you have to look at the consciousness level, activity level, tone, the reflexes, autonomic nervous system, seizure. So, fill these criteria, you will know where the baby stands. So, mild, moderate or severe. This is the Levine staging. Almost most of the so here around 6-7 criteria. Here only there are 4 criteria: level of consciousness, tone, reflexes, especially the primitive reflexes and seizures. So, based upon these 4 criteria, Levine staging came up, and the newest addition is the Thompson scoring. So, Thompson scoring also mostly the level of consciousness, tone, reflexes, etc. Fontenelle has been introduced in the Thompson scoring, and with the scoring you will give 1, 2 or 3 or 0 if it is normal, and depending on the final score you can classify as mild, moderate or severe. If the final score is more than 15, it is severe. If it is 11 to 14, it is moderate, and if it is 0 to 10, it is mild. So, these are all the organ system dysfunction in perinatal asphyxia. So, if it is the CNS, we know it is hypoxic ischemic encephalopathy. There can be seizures and there can be intracranial hemorrhages, and long-term neurological sequelae will occur. Cardiac complications are immediate. There will be myocardial dysfunction, rhythm abnormalities will be present, CCF. Renal hypoxia can result in tubular necrosis, hematuria and renal vein thrombosis. Pulmonary dysfunction, there can be meconium aspiration, surfactant depletion and finally PPHN. GI tract, there can be necrotizing enterocolitis and hepatic dysfunction. Hematological complications are thrombocytopenia, coagulation abnormalities. Metabolic complications are hypoglycemia, hypocalcemia, hyponatremia and acidosis. So, why are these important? When you have a newborn with HIE, monitoring of all these organ systems are very, very important. Okay, so you should anticipate, you should know what will occur, and only then you will be able to test or investigate and manage accordingly. So, HIE evolves from the first few minutes to hours and days later. It keeps evolving because first initially there is a hypoxic ischemic event that results in a primary energy failure. When we don't intervene at the primary energy failure, most often it occurs in utero. Okay, if we do, otherwise if there is a improper or inadequate resuscitation efforts, what happen? Subsequent injury will happen at the penumbral region, not just the infarcted region but the surrounding penumbral region because of the reperfusion. So, the reperfusion happens and free radicals will further exacerbate or further cause secondary injury. And this penumbra will undergo apoptosis even after the insult is over. So, the HIE keeps evolving right from the insult, primary energy failure, penumbral region reperfusion, and then there is a secondary injury also. So, the time gap between these two phases will be somewhere 6 hours to 24 hours. So, there is a window where we can intervene. So, this is a place where this is the time where there is the insult. Within the first 30 minutes when we intervene, okay, the neuronal death will slow down When we don't intervene, what happens? There is a latent phase where it will keep continuing. More and more oxidative stress are there. More and more excitotoxic neurotransmitters will get released. Myocardial dysfunction will occur. Penumbral region gets the reperfusion, and there is a prolonged neuronal death. So, this oxidative stress, the excitotoxicity, the inflammation, all these will exacerbate the neuronal injury. So, this is why the HIE keeps evolving, and our examination, clinical examination should continue to look for any abnormalities. So, the time frame is very, very important. What do you expect in the first 12 hours, after first 12 hours, and in the first 3 days and after 3 days? This is very important because we know HIE evolves over the first few days. So, in the first 12 hours of birth, the encephalopathy, newborns will appear very dull, decreased alertness, hypotonia, there can be seizures, periodic breathing or respiratory failure requiring ventilatory support can be there. Pupillary responses are intact. In the next 12 hours, the alertness level can change. The convulsions, jitteriness will be more. Weakness will start appearing at the end of 24 hours, and more upper limb involvement than the lower limb involvement in term neonates, whereas in preterm neonates, lower limbs are involved more. After the first 24 hours, the alertness decreases. There will be pupillary abnormalities which was intact in the first day. Here pupillary abnormalities, respiratory arrest, prolonged apnea needing support will be present, and this is the time where the preterm neonates will suffer from hemorrhages, intraventricular or periventricular hemorrhage. Beyond 3 days, the alertness will decrease further. Babies will go for stupor, the sucking movements, swallowing, gag, everything is abnormal, needing support. Hypotonia and then hypertonia and finally weakness. So, our management will be based on, it is only supportive care, but optimize the oxygenation, ventilation, optimize the perfusion, the metabolic abnormalities have to be corrected, no hypothermia, no hypoglycemia, no hypocalcemia, and effective control of seizures. So, once a baby is born at the delivery room, if you find that the baby needs resuscitative efforts, immediately take the cord blood pH. So, the pH less than 6.7, you know, it is going in for severe asphyxia, right? So, presence of metabolic acidosis indicates that the asphyxia was long, and this is important. The cord blood pH is important for a medico-legal point of view also. So, when there is cord blood pH telling that the pH is less than 7 and base deficit is indicated as more than 16, it means that the asphyxia is long standing, not the birth asphyxia. It was there in the peripartum or the it has occurred over a few minutes to hours. So, that is the importance of cord blood gas. And when should you admit these babies in NICU? The APGAR score is low, that is less than 3, which is severe birth asphyxia, or babies who required prolonged bag and mask ventilation, who required chest compressions, need immediate NICU care, and even those mild to moderate HIE where the babies are good, alert and taking the respiratory efforts are good, they need to be assessed or monitored very frequently for the development of seizures and any other features of HIE. So, ideally, if they do not receive intensive support, these newborns are nursed in the newborn nursery and with careful monitoring. So, the care in NICU will be to maintain a good metabolic milieu. So, maintain normal temperature, avoid hypo or hyperthermia. Maintain normal oxygenation. So, if the baby has good spontaneous respiratory efforts, oxygen hood is started and with saturation should be maintained more than 90%. Assisted ventilation is needed if there is apnea or if the breathing efforts are not spontaneous. So, maintain PO2 above 60, PCO2 up to 45 permissive is allowed. So, always remember what is the lowest PO2 you will allow and highest PCO2 you will allow. So, avoid both hypo and hypercarbia. So, hypocarbia will reduce the cerebral perfusion. Hypercarbia will increase the cerebral perfusion and intracranial pressure. Maintain normal tissue perfusion. So, if the baby is under hypotension, so start giving fluid boluses and place an arterial line, and if after fluid boluses, if there is a need of inotropes, start with dobutamine or dopamine. Dobutamine is preferred. And correct hypo or hypernatremia also, there is a risk of SAIDH in these babies, so restrict fluids if there is hyponatremia. Maintain blood glucose levels between 75 to 100. Check the hematocrit, it should be between 45 to 55. Anemia and polycythemia both are dangerous. If there is polycythemia, that is PCV more than 65%, bring it down by partial exchange. Maintain the serum calcium concentration in the normal range. Treat the seizures. There is no role for prophylactic phenobarbital. Please understand, no role for prophylactic anti-seizure medication. What about feeding? We can start oral feeding if the neonate is hemodynamically stable, there is no vasopressor support, and you examine the perabdomen, there is no distension, bowel sounds are normal, baby has passed meconium, we can start minimal enteral nutrition and then keep increasing gradually. So, what are the special investigations? EEG and imaging, etc. So, first is EEG. So, it is not routinely indicated in all asphyxiated neonates. In mild, definitely not indicated. But if there is onset of seizures or there is a moderate to severe birth asphyxia, definitely EEG will help in prognosticating. Multi-channel EEG with video is the gold standard. Similarly, what we have seen or discussed in our newborn seizures. So, a continuous video EEG is the gold standard for the birth asphyxia also. And there are certain findings in the EEG which will tell you that there is a poor prognosis. So, what are those poor prognostic findings in EEG? Number one is burst suppression. So, burst suppression has got a poor prognosis. Isoelectric pattern. Long periods of inactivity. For more than 20 seconds, there is no electrical activity. Then, interhemispheric asymmetry or asynchrony between the two hemispheres. Isoelectric or low voltage, that is less than 5 microvolts. So, any of these 5 EEG findings means there is a poor prognosis for that particular newborn. So, burst suppression, we know it is associated with many malignant epilepsy syndromes. Similarly, when there is inactivity or isoelectric line, definitely there is a poor prognosis. So, remember that these few findings of EEG, when you have received such an EEG report, it means there is a poor prognostic indicators. And amplitude EEG, of course, is a simple non-invasive technique that we do bedside in NICU. Continuously, it is given for moderate to severe birth asphyxia. Very, very importantly, the sleep-wake cycle. So, the time of onset of sleep-wake cycle is of prognostic value. If the sleep-wake cycle does not return even up to 36 hours of age, it means a bad prognosis. Okay. So, there should be a sleep-wake cycle difference. If it does not appear by 36, it means bad prognosis. Okay. Cranial ultrasound, of course, it is done bedside. So, this will give you an idea of the HIE changes. So, any hemorrhage or hemorrhagic infarctions, are there any hypoechoic areas? Preterm babies, you can look for PVL, etc. So, cranial USG is very, very useful for preterm newborns. Neuroimaging, CT or MRI, if MRI is not readily accessible, CT can be done in initial stages or in an acute stage of HIE. CT will show only low attenuated areas of wherever the ischemia has happened. After several weeks, we will be able to find that the injury areas, especially in the deep cerebral hemisphere, deeper cortex or basal ganglia injury or thalamic infarctions, etc., we will be able to identify. And MRI, of course, is better for prognosticating, and if one needs to identify abnormalities very early, diffusion weighted imaging as early as day 1 end or day 2 of life, diffusion weighted imaging will be able to identify the abnormalities. Or we can go for a conventional MRI after 3 to 4 days of life. Ideally, we do at day 7. Any birth asphyxia we perform an MRI at the end of the first week of life. And again, for prognosis, the posterior limb of the internal capsule, if there is an altered signal, then it means there is a poor neurodevelopmental outcome. So these are all the findings of MRI which will give a bad prognosis or a good prognosis. So most often when we have a plic abnormality, this is one poor prognostic indicator, and mostly in this watershed areas or the parasagittal regions, there will be abnormalities. So again, EEG abnormalities we have mentioned already, so I am skipping here. So specific treatment of HIE. So far we have seen how are you going to manage the supportive care, everything we have seen. Specific management will be therapeutic hypothermia. Of course, therapeutic hypothermia, I have a separate PPT, so I am not discussing here. And what about prophylactic phenobarbital? Previously, it was practiced that prophylactic administration of phenobarbital had a better neurodevelopmental outcome, but however, one of the recent Cochrane reviews concluded that it has no difference in the risk or neurodisability. So prophylactic phenobarbital is not given. But although there are many drugs now under investigation like antioxidants, free radical blockers, calcium channel blockers like flunarizine, imodipine, and NMDA receptor blockers, etc. So all these are still under investigation. So the specific treatment for HIE will be therapeutic hypothermia. So therapeutic hypothermia, we know when should we start, how long it should go, what are the criteria that the newborn has to satisfy before starting therapeutic hypothermia. Two different types, head cooling and the systemic cooling. Everything has been discussed in another presentation. Do not forget to go through that also. So now coming to how are you going to follow up. So every time when you write an exam, the exam paper or any question in your exam, finish it off with a prognosis or how are you going to follow up. Okay. So all moderate and severe asphyxia should be followed meticulously. The neurological examination should be performed completely at every follow up, and a formal psychometric assessment at 18 months should be done in these asphyxiated children. So severe basal ganglia or thalamic injury, mostly 98% they result in cerebral palsy. So you have done an MRI and you find that there are basal ganglia and thalamic infarcts. 98% of these will result in cerebral palsy. So special attention to these children, their feeding, speech and language, vision, developmental abnormalities, everything has to be taken care of. Seizures, of course, if the cortex abnormality is present, and they will have seizures also. So following up these children with cerebral palsy and good supportive care with respect to feeding, speech, vision, hearing, etc. is very, very important, and a careful control of seizures with good anti-seizure medication is very important. And I'll just complete with the prognosis. Okay. So, what is the prognosis with respect to the mild, moderate and severe? Mild HIE will mostly they are free from any neurological sequelae and free from death. Moderate HIE, 5% of the newborns die. 1/3 to half, 30 to 50% may have serious long-term complications. Stage 3 HIE, 80% dies, and the remaining 20% will have definite neurological sequelae. So this is more easier to remember. Again, some predictors of bad prognosis I have mentioned here. This is from the Nelson textbook. So very low Apgar scores at 20 minutes. Time to establish spontaneous respiration. So even after 30 minutes, the baby does not have spontaneous respiration. Newborn neurological examination is abnormal. Abnormal brain imaging and other investigations like EEG or BERA is abnormal. So all these are predictors of mortality and neurological morbidity after a perinatal HIE insult. So this is something which is asked mostly in the viva by the external examiners, and many researchers have mentioned that an IQ less than 70 at 6 to 7 years of age is less for newborns who have undergone hypothermia. So therapeutic hypothermia is the definitive treatment for moderate and severe perinatal asphyxia. Okay, so this again has been mentioned in our therapeutic hypothermia presentation also. So with this we come to the end of this presentation. So approach to HIE is very important. Start from your history, examination, poor prognostic indicators, how are you going to investigate HIE, how are you going to manage that complete supportive care, and finally finish off with therapeutic hypothermia and prognosis of HIE. What are the predictors of a bad prognosis, right? So I hope this presentation is helpful and easily understandable by all of you. Any questions, any doubts, please reach out to us. We will be happy to clarify those. Thank you everyone for the patient listening.